similar to the previous talk, PNH is also classed as a very rare disease. So just to get familiar with the voting system, my first question is, how many patients with PNH have you seen in the last year? Now, by that, I actually mean any proportion of PNH cells, from tiny up to the very large clones. So if you could vote now. It's not active yet, I've been told. Obviously, so for those of you who've sat in the clinics, if you've seen more than 8 patients, you'd be classed as a world expert, because most haematologists only ever see 0 to 1. But this is why, when we're very fortunate in the UK, where we centralise the care. In Leeds alone, we look after over 500 patients with PNH, and we are regarded as the largest PNH centre in the world now. So anyone who would ever like to come and sit in one clinic, you'll see 20 patients in one day, and you'll become a world expert quite quickly. No problem. Okay. So let's have a show of hands for that one instead. Who's seen less than 5 patients? So the majority of the room. And greater than 5 will be the rest, I presume. But show of hands just so that I know where you are, if I need expert help. Right. This one I think will work. Is that one? Yes. PNH arises on the background of a bone marrow failure condition, either aplastic anemia or myelodysplasia. What percentage of patients with aplastic anemia do you think have a proportion of PNH? And those are the options available. So we have answers already coming through. Okay. And the most popular is certainly the 1 to 20%. And the correct answer is number 4. Approximately 2/3 to 70% of patients with aplastic anemia have PNH cells, and that's including at the very low level. And by the very low level, I am going to proceed to this case. A 46-year-old female, this is just one slide on this, she does have aplastic anemia. As according to the British Society guidelines, she's tested for PNH, and she's found to have a very low level. Just 1% of her cells are PNH granulocytes, and obviously far lower in the red cells. So the question to you is, does this flow cytometry result affect her management, or is it relevant for her onward management of aplastic anemia? And if you could vote now. So the results coming through suggest most think that that result isn't relevant to her aplastic anemia management. And then the next is that people think it's relevant to her imminent aplasia treatment. And quite correctly, very few think it's relevant to PNH treatment. The reason it's interesting to know if a patient with aplastic anemia has any PNH cells is because of the prediction of response to immunosuppressive therapy. And I'll go on to a subsequent slide that will show you the link with the immune system, and therefore why they may have a better response rate in aplasia if you find PNH cells. This is another patient case, a 20-year-old female who is diagnosed again with aplastic anemia in December 2010, and she receives her immunosuppressive therapy. In 2012, her haematologist notes that she has an 8% population of PNH granulocytes. So my question to you very quickly is, would you refer this patient to the National PNH Service? Don't be biased because I'm standing in front of you. But answers just yes or no. Oh, well, 93% have said yes, so that's excellent. Thank you very much. Now, why would we want a referral? Well, first of all, we will just go into some brief background on PNH. PNH is an acquired disorder, and that disorder that's acquired is a mutation in the PIG-A gene. This therefore means it's not inherited. It can occur at any age from childhood to elderly. And if you acquire that mutation, there is a loss of this structure, the GPI anchor, and through that, many proteins that normally attach to the cell membrane will be absent. And dozens of proteins have been identified that link to the cell membrane through the GPI anchor. But for the purposes of PNH, it's the complement regulatory proteins, CD55 and CD59, that confer the clinical risk and the symptoms. I've been told by the trainees in Leeds that one of the MRC path questions last year was, which is the most important loss in terms of conferring the clinical consequences of PNH? Is it CD55 or CD59? And I was alarmed that even in Leeds, only half, it was a 50-50 answer. But here it's looking far, I was going to say better, but we'll see. Yes. Currently, with the results coming through, 2/3 are saying CD55. The answer is CD59. So clearly, I need to do a bit more education. In the past, we used to talk about both similarly. CD59 is what prevents the binding and forming the membrane attack complex through the C6 to 9 pore that can form. And CD55 targets more of the proximal complement system. When we get to the complement cascade slides, I can spend a long time on them if you would like. But let's go back to the pathophysiology. As I've said, it is an acquired mutation, and that mutation is actually occurring at quite a high frequency to any of us at any time. And looking at the numbers in this room, there are probably about 10 people here today who have an acquired mutation in a PIG-A gene. So let us say that you are now sitting here with a PNH stem cell in your own bone marrow. But PNH itself is not malignant. It doesn't have its own proliferative advantage. And so it will stay at a very low level unless, and this is where the rarity will come in, you are unlucky enough to also develop a bone marrow failure problem. And again, looking at the age group in this room, the most common one would be aplastic anemia. What we think happens in aplastic anemia is an immune attack that targets the normal stem cell. But for reasons, despite decades of research, the PNH stem cell is spared. More recently, we believe that there is supposed to be a third step that does confer a proliferative advantage, but that step has not yet been found. But when these PNH stem cells are spared that immune attack, it's simply now survival of the fittest. And those PNH stem cells can be classed as stronger than normal, and they do proliferate, and they become the bigger population in the bone marrow. Obviously, these two steps may be reversed. You may first have a patient with aplastic anemia and a negative PNH screen. But because that mutation can occur at any time, we have to be regularly looking for PNH cells in this population of patients. So if those PNH stem cells do expand, they produce PNH red cells, PNH white cells, and PNH platelets. And historically, the textbooks only talked about the red cell consequences. But we know, and particularly where thrombosis has occurred, that it's due to the activation of the white cells and the platelets. So actually, your population of PNH white cells are the most important to monitor. It doesn't matter how much your patient is hemolyzing, you look at the LDH, but please look regularly at the PNH granulocyte and monocyte population, because this is what will be helping to predict those patients who may go on to have a thrombotic event. So I think as haematologists, we're very good at testing all our aplastic anemia patients by flow cytometry. So my question to you now again is, if you have a patient who has some PNH cells, how often would you repeat the flow cytometry? Would you repeat the flow cytometry? And then there are various options there. So if you could vote. fluctuating a little bit, but the three most popular answers are numbers 3, 4 and 5, 3 monthly, 6 monthly or yearly. So what do we recommend for the frequency of monitoring? Well, this is now in the British Society guideline for aplastic anemia. If your patient has a tiny population of cells at the diagnosis of their aplastic anemia, we actually say test 3 monthly for the first 2 years and only reduce the frequency if it remains stable. And that's simply because every large P&H clone started as a tiny P&H clone. And you don't know when you first test that patient as if you've caught them at the time when they're about to suddenly expand. If the P&H screen is negative, we say test 6 monthly for the first 2 years and then reduce to annually just to ensure they haven't acquired the mutation. And if it becomes positive, they move to the left-hand side of the slide. And that is now in the BCSH guideline. And this is simply cases like this, and we have many every year. This patient had an 8% population of cells, which in 15 months was near 60%, and this lady who had 10% and within a year was up at 70%. If she'd presented with a thrombotic event at this point, quite rightly her admitting team would have said this isn't due to PNH, it was only 10%. And what they haven't picked up is that it has expanded quite significantly in just a few months' time. So 3 monthly for the first 2 years when you detect a new patient. So we'll go back to our 20-year-old who, as you remember, had an 8% population of PNH granulocytes. Her haematology team commenced her on cyclosporin. They stopped the cyclosporin, she relapsed. She wasn't very compliant with hospital visits, so we need to remember that. But the local team did write at one point, she has a significant PNH clone and she is hemolyzing, sufficiently enough that they commence her on folic acid. She's very anemic, but reasonable platelets, white cells and neutrophils. In 2016, it's actually documented she has hemoglobinuria. Yet, unfortunately, we are still not aware of her in the PNH service. And just the month after that was reported in a clinical letter, she was admitted with a severe headache, blurred vision and hemianopia. Her population of PNH cells is 80%, and that's across the 4 years that between the 8% and 80%. She has a very high LDH, and the CT scan confirmed a stroke with a temporal lobe infarct, a 6th nerve palsy and papilledema. So she commenced low molecular weight heparin in her local hospital. A few days later, we received the call in Leeds and we shipped emergency complement inhibitor therapy down. She was in hospital for nearly 1 month and she was discharged in a wheelchair after some rehabilitation. So it is a devastating disease. It's also a disease that causes stroke in young patients. It's something, therefore, we need to be thinking about and why I believe we exist as a national service. She was eligible. We have criteria for treatment. She would have been eligible for treatment far earlier if we'd have known of her. But thrombosis is the complication we worry about the most, with the highest morbidity and mortality. And I think we have moved away from inherited thrombophilia screenings for many unprovoked, undiagnosed causes of thrombosis. But this slide shows the high rate of thrombosis if you have PNH, which is a rare disease, compared to the inherited thrombophilias. And I think in diseases like PNH, antiphospholipid syndrome, and where you have a JAK2 mutation, these are conditions where we could actively change the prognosis for the patient, and so could be far more useful to test for those 3 conditions than many of these in a patient with an unprovoked thrombosis where the cause is not known. The next thing to mention is the site of thrombosis, because again for PNH, the textbooks will talk predominantly about the unusual sites, such as the Budd-Chiari syndromes, which in this small survey that we did was the commonest site of thrombosis. But that simply is because we are very good at testing patients with unexplained Budd-Chiari for PNH. But PNH is simply a prothrombotic disorder. And actually, in larger studies across 3 countries, the commonest site of thrombosis is the simple DVT and PE. And this is why I do believe there are patients with PNH hiding in some of our hemostasis and thrombosis clinics who are not yet diagnosed. Arterial thrombosis is also significantly increased in this disease area. So in a publication in Blood a few years ago, really it's those patients in the past who you would have considered doing a thrombophilia screen on. Again, I could put young in inverted commas. It's who you think is young but has an unexplained, unprovoked thrombosis. This is obviously the most important point. If they are young, if that thrombotic event is in an unusual site, or if they have evidence of hemolysis, or if they have a cytopenia. Now, again, we could argue about the significance of that cytopenia, but I'm going to present another couple of cases to try and highlight some of the interesting points on that shortly. Anticoagulation is used and has been used as prophylaxis in the past. However, we know it doesn't work in PNH for the majority of patients, with patients still thrombosing despite anticoagulation. And this is a paper written a few years ago in Blood talking about the link between the coagulation system and the complement system in PNH. There are many multiple mechanisms that this paper discusses, and again would be maybe a topic for another talk to talk through some of these potential mechanisms. So my question to you now, if you have a patient with PNH who has previously had a thrombotic event and is commenced on a complement inhibitor such as eculizumab, would you discontinue the anticoagulation? So a simple yes or no answer. And just in the interests of time, most people are saying no. And that is our current UK practice, is that we do not discontinue anticoagulation unless the patient has a source of bleeding, such as gastric varices, or if they are thrombocytopenic. That's making us very cautious. In the States, they are stopping anticoagulation. And actually, if complement inhibition is maintained, they don't have any further thromboses. So we're probably being overly cautious here, but we're continuing to anticoagulate these patients. Another case at this point, and this is a patient from the South Coast, a 49-year-old male who was fit and well. He was running marathons until one night in November 2012, when he had a cardiac arrest after his wife had called an ambulance. He went straight to the cardiology intervention suite, was found to be having an ST elevation MI, and had a stent inserted. What the cardiologist wrote that night was of great interest. He wrote that there was a clear occlusion, the blood clot, in the middle of the left anterior descending artery. But the exact words of the cardiologist were that the rest of the coronary arteries were pristine. They were clean. This young man had no evidence of atherosclerosis. This MI did not arise on the background of atherosclerosis. They did what they do for any patient having an MI and having a stent, placed him on triple anticoagulant therapy, and they discharged him. I can tell you, because I've checked, his hemoglobin was normal, his white count was normal, and his platelets were just 120 times 10 to the power 9 per litre. So this is a very mild thrombocytopenia. Obviously, no one picked up the phone to a haematologist. Why would they? But if they had, would you test for PNH at this stage? You have to, do not be biased. What would you have done if this had been a phone call to you? Yes, absolutely. Yes, so it's nearly 50-50 in the answers, but 60-40 to no. And I don't think that's unreasonable. No one would have thought about testing for PNH. But could I just say now, this patient has an unexplained, unprovoked thrombosis with a cytopenia. Just something to think about. So what happened to him anyway? He came in a few months later with severe lethargy. He'd had some tunnel vision which had resolved. The SHO did an ECG, and because there were no changes, he's discharged again. Remember, he's on triple anticoagulant therapy. He comes in again the next month with critical limb ischemia of the left leg. He's also got renal infarct, splenic infarcts. I won't read all of that, but he's clotting lots of vessels. He's got pulmonary emboli, and he's got a left ventricular thrombus. So again, I've read the notes, and the medics, it wasn't unreasonable what they wrote, which was, he's had an MI, he must have an akinetic left ventricle, or reduced kinetic left ventricle, which has developed a thrombus. This thrombus is throwing off emboli and clotting everything. It didn't explain the pulmonary emboli, but they were happy they had an explanation, so they continued triple anticoagulant therapy, and they discharged him again. He's still alive at this stage, but he comes in the next month with a stroke and Budd-Chiari syndrome, and it was genuinely the gastro-SHO who made the diagnosis of PNH, and phoned us in Leeds, and we shipped drug down to that hospital that day. He was clotting regularly. He would have succumbed, I'm sure you can see, from those frequent clots. He's had no further blood clots. He's doing well several years later. But what if we had tested after the MI? Could we have prevented the strokes, the Budd-Chiari syndrome, the renal damage, etc.? So although I know it's unfair, it's now educating our colleagues around the hospital that these patients with unusual or unexplained, unprovoked thromboses should probably see a haematologist sooner. And we're getting referrals still where catastrophic problems have occurred, particularly, I think, in young adults, because it's taken 9 months for the referral to come to haematology, and in that time they've had repeated thrombotic events. This patient is a 32-year-old who already has a diagnosis of PNH. She's had headaches for about 6 weeks with no nausea and vomiting. She had some paresthesia, temporary weakness of her left arm, which resolved. She had a CT scan and an MRI scan, which were both normal. She's commenced on low molecular weight heparin because we're worried about those symptoms, but the CT and the MRI are normal. So if this was your patient, what would you do now? Would you continue to observe but stop the anticoagulation? There's no evidence of a thrombosis. Would you continue anticoagulation, or would you do any more imaging? We don't have that question on the interactive element. So I will say that what we would do, and this patient did actually come to Leeds teaching hospitals, where the radiologists know us very well. So despite the normal CT and MRI, it's an MRA that we need in this group of patients. And she had had a superior sagittal sinus thrombosis, and obviously that may not show up with the other imaging. So the real lesson from this point is to not really back down if you have a patient with PNH having unusual symptoms. Sometimes we have to go further with our investigations to find the complications. She was actually a patient who entered one of the clinical trials for eculizumab many years ago in 2005, and she was well for a number of years until October 2009. And then in that month, she was admitted with a pyrexia and a headache. She's not neutropenic. Aplasia is not a problem for her. She has a significant proportion of PNH cells. She's hypotensive, tachycardic, with a slightly high respiratory rate. So what do you think is happening to this patient? Does she have an exacerbation, a further thrombotic event, septicemia, an overdose of eculizumab, or is she developing aplasia? If you could vote now. Wow, that's quite impressive. The correct answer came up quite quickly for many of you. So the correct answer is that she has septicemia, you can tell from those parameters, and it's secondary to meningococcal infection. Because these patients have been terminally complement inhibited, we know they have an increased risk of meningococcal infection, and we need to be vigilant for that. And currently in the UK, there is an increased incidence of Neisseria meningitidis infection, not just in PNH patients on eculizumab, but actually in the general population, including babies. So we have to be very vigilant. And some of you here, I know, help us when we're on call, because our patients are all throughout the country, and it's you that will help us manage those patients in the local hospitals. I'm actually going to skip over this next case. I've just got a few minutes left. If I press escape, can I jump ahead? I had many cases which we can save for another time. Is that easier? So I'm going to finish with this case, which I know one or two in the audience will recognise. This is a young woman who at the age of 16 back in 1997 was diagnosed with classical PNH, which was hemolytic and transfusion dependent and had never had a history of a thrombosis. She was commenced on eculizumab in 2002, so she was one of the first patients in the world to receive a complement inhibitor therapy in the pilot study that we did in Leeds. It worked very well. Her LDH fell from over 4,000 down to the near normal range. Transfusion independent, and then in 2007 she became pregnant. So she was actually our first patient on a complement inhibitor therapy where we had to make a decision and decide, does she continue on the complement inhibitor or should she come off? Historically, obviously, patients with PNH were discouraged from getting pregnant, both from maternal and fetal complications. The young woman elected to continue her complement blockade, and at that time, with little experience, we also added in therapeutic doses of low molecular weight heparin. Remember, she'd been transfusion independent, and she now became transfusion dependent. And this slide shows what was happening with her. At week 28, when we were analysing, you can see that her urine is clear, but on the day that she's due an eculizumab infusion, her urine becomes dark. Her LDH has become elevated, and the PK level of eculizumab has fallen. So again, if this was your patient, what would you do now? Would you recommend urgent delivery of the baby? Would you increase the dose of eculizumab, increase anticoagulation, or continue supportive measures? If you could vote. So again, a very quick answer that more than 90% or 80% would increase the dose of eculizumab. And that is what happened. And we alter the eculizumab infusion schedule. 2/3 of pregnant women will clear their drug faster and need a higher dose of eculizumab in pregnancy. When we altered the schedule, she did very well. She delivered her baby, and we have analysed cord blood and breast milk to see if these patients can safely breastfeed, for example, and it looks like they can from the results that we've had on several patients. Since then, this young lady had a second pregnancy and another successful delivery, and then she got pregnant for the third time. So remember, she was 16 when she was diagnosed, and she was told at that time never to get pregnant. So she managed to now have the family that she never thought she would be able to have. So just to scare us even more, she went on and had her fourth child as well. So I just think it's a great success story for these patients. With pregnancy and PNH, they do need to be referred to an obstetric haematology clinic for very close monitoring. We have got newer complement inhibitor therapies in development. It is a disease that affects many young patients, and actually in one case series, 20% of diagnoses were made in pregnancy, because that was the first time the women had a full blood count done, very much like chronic myeloid leukemia. If that happens, please contact us. We will help support through the pregnancy. But pregnancy in the UK is an indication to start eculizumab therapy. As mentioned, it doesn't appear to cross the placenta or be excreted in the breast milk. We don't have enough data on the newer complement inhibitors in development, but we're certainly asking the companies to look at this very carefully. So this is that young woman who actually had the 4 babies, and we've had now, from the Leeds Centre alone, we've managed more than 47 pregnancies for patients with PNH on eculizumab. So you can see how we believe it has been hugely successful. And this is the National PNH Service team, both the London and Leeds doctors and nurses. So thank you very much for your attention.